In this video, we will show an implantation of a CRT defibrillator. A cephalic vein cut-down will be used to implant the RV and right atrial leads. The cephalic vein can be directly accessed through a small incision. A small vein hook tool is used to acquire a visual into the vein lumen. This enables the direct introduction of the lead into the venous system. The distal ligation suture wire can be used to apply tension on the vein for easier introduction. In this case, it is the RV ICD lead which will be first implanted. The lead should advance easily into the cephalic vein and towards the heart. But then fluoroscopy is needed to help us guide the ICD lead into the RV. The stylet often needs to be curved in order to enable better guiding of the ICD leads towards an adequate RV position. The lead will now be positioned on the RV septum with some back and forth maneuvers. The fluoroscopy tube is then turned into a left anterior oblique position to enable confirmation of the lead location. The lead tip is pointing towards the RV septum. The lead needs to be applied firmly onto the myocardium to ensure proper deployment. A lead fixation tool can then be applied so the helix can be extended into the myocardium. The tool needs to be rotated slowly around the lead in order to advance the helix firmly. Fluoroscopy shows a stable lead position with helix extension. The ICD lead is now fixed onto the RV septum. The lead can now be given some slack. By applying the electrodes, we can now perform lead tests. The lead senses at around 13 millivolts. Impedance is around 730 ohms. We will now commence pacing with decreasing output amplitudes. The pacing threshold is below 1 volt, with loss of capture at 0.4 volts. The RV pacing threshold is therefore 0.5 volts. Next up is the right atrial lead. This is a sonar lead, meaning it measures heart contractility in order to optimize CRT therapy. The lead tip needs to be submerged into water in order to expose the helix after a few minutes. The lead could not directly be introduced into the cephalic vein due to resistance. Instead, a guide wire was first advanced into the cephalic vein. Over which an introducer was placed into the cephalic vein. Note the above average venous blood return, typical for CRT candidates, which are patients with congested heart failure. The right atrial lead can now be advanced into the venous system and the introducer peeled away. The right atrial lead is positioned into the right atrial appendage. And then the lead is slowly rotated, which allows the exposed helix to turn into the myocardium. The J-curved stylet is exchanged for a straight stylet in order to expose the final position of the lead in the right atrium. The lead position is adequate and stable. The lead can now be connected to the programmer to allow testing. The lead senses atrial events at around 2.3 millivolts, and the impedance is around 500 ohms. We can confirm atrial capture by looking at the atrial EGM, but also on the 12-lead ECG, which shows P waves after every spikes. The right atrial lead is below 1 volt, which is excellent. 0.4 volts to be exact. In order to place a left ventricular lead into a coronary vein side branch on the LV, a guiding catheter needs to be placed into the coronary sinus, CS. In this case, a steerable catheter is placed within the CS catheter in order to facilitate introduction into the CS. First, the steerable catheter is placed into the CS, in this case directly into a side branch. Then, the CS catheter can be advanced over the steerable catheter into the CS. When the guiding catheter is placed in the CS, we can prepare the contrast injection into the coronary veins. The venographic catheter allows contrast injection and distal tip balloon inflation at the same time. The venography catheter is advanced into the CS guiding catheter. While the inflated balloon blocks the CS, the contrast now exposes a suitable lateral side branch. A quadrupolar LV lead is now introduced into the CS guiding catheter. And a very thin guide wire within the LV lead with a floppy tip is placed within the coronary vein side branch. The LV lead is now advanced into the side branch over the guide wire. At this time, there is an important interaction between CS guiding catheter, the LV lead, and guide wire. This guide wire is moved back and forth in order to guide the LV in a suitable vein. The LV lead needs to be advanced, with the guiding catheter stable in place, in order not to withdraw the lead into the atrium. Finally, the LV lead can be advanced over the guide wire into a vein which seems of adequate size. The LV lead should be wedged into stable position with all 4 electrodes in the side branch. This position looks interesting with all the electrodes on the LV. Let's hope there's good LV pacing threshold and that there is no phrenic stimulation at low outputs. We can now perform pacing tests, starting at 10 volts. We indeed see phrenic stimulation with moving of the abdomen. But it's not present at 5 volts, meaning phrenic nerve stimulation will not happen during follow-up. We will then decrease LV pacing output further. The EGM and ECG both show that the LV lead is capturing. And we will find a low threshold of 0.4 volts. With the LV lead in place, the CS guiding catheter needs to be peeled away using a cutter tool. This is a very important step of the implantation because there is a risk of displacing the LV lead with loss of CS access. The LV lead needs to be tested again as it may have been moved during the slitting process. Phrenic nerve capture is stable, present at 10 volts but not at 5. The LV pacing capture is still excellent. Well below 1 volt, which is not always the case for this epicardial pacing method without lead fixation. Finally, the 3 leads need to be connected into the CRT D header. Lead ports differ between companies, so it's important to identify the proper channel for each lead. With the RVDF4 ICD lead in place, we now proceed to the quadrupolar IS4 LV lead. The leads are advanced with visual confirmation that the proximal electrode is all the way through. Finally, the right atrial lead can be connected to the CRT D device. Notice how a slight tug on the lead confirms adequate fixation into the header. The CRT D device can now be inserted into a pocket on the pectoral muscle.